and it's about the dilemma of venous stents. Dr. Amr is, of course, one team member and quite dynamic chap, and I think he will be properly replacing our colleague, Professor Abdurrahman Salim.
Thank you very much, dear colleagues. Dilemma of venous stent. Characteristics of an ideal venous stent. Adaptability, a wide range of size and length to be fit different clinical scenario. Strength, able to resist recoil and compression. Flexibility, able to negotiate the curve of the pelvis without distortion of the stent vein. Durability, able to withstand repetitive motion without loss of integrity. Aspect of strength, chronic outward force, radial force during expansion, occur without balloon dilatation exerted on vessel wall. Radial resistive force, resistance to the recoil, occur after a stent is dilated with balloon. Consideration for proper placement. Vein curve through the pelvis. Landing a stent at the bottom of the curve may lead to kinking. Consideration of point of compression, confluence, and angular ligaments. We have too many different type of stents. We have wall stent, which is braided eligloy, Vichy, which is closed cell nitinol, Venovo open cell nitinol, Abri open cell nitinol, Zervavina open cell nitinol, Vivid Due open cell nitinol. Wall stent, Boston Scientific, eligloy closed cells, higher radial force except for the end of the stent. Large sizes tend to foreshorten, less flexible, resist crushing. Accurate deployment can be an issue, but can recapture, adjust to a point. Nitinol stent, multiple manufacturers, self-expandable, chronic outward force, resist recoil, which stent compression, easy to deploy, more precise placement, minimal foreshortening, radial force vary, longer length available. Vichy stent, Boston Scientific, coaxial 9 French, approved, pulled from market, closed cell nitinol, and we have variable diameter and length. Virtus trial, a prospective non-randomized international multi-center study, had stent fracture during this trial. Study population over 170, 75 post-thrombotic and 25 non-thrombotic. And the outcome primary patency at 12 months was 84 and 98 freedom from major adverse event at 30 days. Venovo stent barred, Venovo triaxial dual thumb wheel, French 8 to 10, approved, open cell nitinol, and have variable diameter and length also. Vernacular study, a prospective non-randomized international multicentric study which collected over 3 years duration. The overall 12-month primary patency was 88.3%, and the BTS was 21.3%, and non-thrombotic lesions was a larger percentage, 96.9%. Abristan Medtronic triaxial thumb wheel 9 French approve, open cell nitinol, and variable diameter and length. Abri study, it collected over 200 patients, and we have primary patency 88%, and the primary assisted 91%, and the secondary assisted was 92%. Sorry. About the major adverse event was 2%. Zervavina coaxial 7 French approve, open cell nitinol with variable diameter and length. Vivo trial, prospective non-randomized international multicentric trial, has completed enrollment over 243 patients, and the 12-month primary patency was 87.9%. So the conclusion, many choices of the stent on the market presents. Two main materials, eligloy and nitinol. Difference in the radial force, sizes, deployment mechanism between the various stents. Familiarity with the aspect of the each stent important for proper deployment and sizing. Thank you.
Thank you, Mahmoud, for your nice presentation. Do we have any questions from the floor? So since you nicely presented all of the currently available stents, how many of these stents have you personally used? And tell us if you feel one stent is better than the other. What is your...
Well, my personal experience was with the wall stent and with Venovo barred stent and with Zervavina. But I didn't touch with Abri. But I think it is like Venovo in the mechanism of deployment. My personal preference was with BARD. It is a venous dedicated stent and presented with a long length. For example, we can use covering the IVC and the iliac only with using 2 stents. About wall stent, it is available in the market in Egypt and it is cheaper, so it is more familiar for us for our practice. But I think that it's rigid and has point of foreshortening and not that accurate deployment like those of the venous dedicated stents.
Indeed. With the, Eman, you want to comment?
I believe that the situation is a bit tricky because unless we do have our own lab for hemodynamics measurements and simulating the real scenario with in some centers in Europe, we will be always unable to get the perfect stent as far as accurate pre-procedural measuring and accurate estimation of the tendency for migration and the tendency for lengthening a little bit if you go to a larger size, which we all experience, and probably Nader over there would agree with me. I mean, in absence of our own hemodynamics lab and simulating models, we are unable to reach that. Would you like to have an input, Nader? Because this juncture of the discussion is probably important for educational purposes, if I may.
Yeah, I think actually because the whole world, and especially in Egypt, we have a lot of financial constraints at the moment. We already had wall stents available on shelf, and we can use them in the university. The other stents are not available unless if someone has a private insurance, and it's not easy to get them for the patients. But I believe actually if we will go through head-to-head comparative studies between the stents, I mean, I had experience with the wall stent only, but I don't think that there is a huge difference from the publications about the results. I think actually the time will tell, because we know that this disease is different than the peripheral vascular disease. It happens in younger group of patients, and we would have longer follow-up, and this will affect, obviously, the type of stent that will show up in the next 5 years or 10 years.
One point I'd like to involve Max again, please, in this respect. Don't go away. Pure iliac stenting is different from iliofemoral because it's always about the inguinal ligament and how much you could be forgiving. The vessel could be forgiving once you try to land on this particular area and respect at the same time the inflow, particularly and the common femoral junction. So you have a sector of the iliofemoral segment that is a bit more forgiving than the others. Do you agree?
Yeah, I agree, yeah. Well, I mean, that you see, we know as well from different literature that actually you don't have the same restrictions of extending the stents down towards the inguinal ligament, unless if you will cover we don't want to cover the profundofemoral vein. But as long as actually we're going down to the inguinal ligament, it's actually accepted in most of centers.
Akis?
Well, you need to cover the disease, and if the disease extends below the inguinal ligament, you definitely have to cover the disease below the inguinal ligament, provided that you don't jail the profunda. And just as a closing remark, because for the interest of time we need to move to the next speaker, the wall stent has been tested in time for the past 10 years. We have the most clinical experience against any other stent, and any studies we now have available against the dedicated novel venous stents haven't shown that wall stent is worse than the other. Actually, all stents right now perform equally. Right. Yes, the wall stent has some difficulties to deploy, it foreshortens, it's weaker at its edges, you have to extend it into the vena cava, risking contralateral DVT, but there is no study indicating wall stent being worse than the others, and it is cheaper.
Definitely.
Right.
With that, I think we can call our next speaker.
Thank you.